Hospital Ethics Committee and faculty of the Vernon Institute of Bioethics. Welcome to Ethics for Lunch, which is a program co-sponsored by the Johns Hopkins Ethics Committee and the Vernon Institute. And today, we are very delighted to have another wonderful panel of our colleagues to take on an issue that many people struggle with at clinical practice at the juncture of patient care. Part of our goal in Ethics for Lunch is to create a forum for us to explore some of these questions and to learn about ways that we can approach these kinds of questions and to learn from different perspectives. And so our panel today is a great representation of that. The panel members include Lee Doherty-Biddison, who is a critical care physician in our medical intensive care unit and a member of our ethics committee, followed by Lynn Billing, who is a palliative care. Yes, Dan? Can you hear? Is there anybody else who can't hear? Lynn Billing, who is a palliative care nurse here in the Sidney Kimmel Cancer Center, followed by Michael Erdick, who is an associate professor in anesthesia and critical care as well as oncology. Unfortunately, our colleague Rhonda Cooper was not able to be with us today because of family emergency, so I'm going to sort of sit in and try to offer a perspective along with our chaplaincy colleagues. So I'm going to turn it over to Lee.
Well, thank you, everyone, for being here today. I understand there has been some technical excitement in the room, which is why we're struggling a little bit with the AV, but hopefully we'll speak up enough to be heard in the back. I want to share with you, we'll talk a little bit about the case. It's on the handout that was available as you came in, but we'll just talk through that in a moment, and I want to, for a moment, and then quickly turn to the discussion. So the patient that we will use as the starting point for our dialogue today is a 68-year-old woman who was admitted with respiratory failure to the intensive care unit. The context of this was that she had underlying chronic obstructive pulmonary disease in the form of emphysema. So baseline had some pulmonary dysfunction, also had hypertension, and importantly, metastatic colon cancer. So she had advanced malignant disease in addition to the underlying diseases. And then she was also diagnosed with the flu. So it was really the influenza that brought her here, but again, a lot of underlying illnesses. In terms of understanding the situation with her cancer, this had been formally diagnosed, and she had been told that she and her family had been told that there were no additional treatment options for her. No chemotherapy, no radiation, no surgery. And in fact, very concerning was that she had metastatic disease to her bones, which appeared to be causing some significant pain. The MICU team, the ICU team that was taking care of her, was very concerned about this. She was mechanically ventilated, so communication was a challenge. But she would, at times when she was either moved or sometimes not being moved, just resting in bed, would indicate or have indications of pain. So she had her high heart rate, high respiratory rate, some grimacing, sometimes diaphoretic, sweating, which were, to the clinical team, suggestions that she was actually having pain that needed to be treated. The point of contention really arose in taking care of this patient when the family shared that they would prefer that the patient not be given the narcotic pain medications that would typically be used to treat a patient with bone pain from their cancer, because they were worried that it made her too sleepy and unable to communicate with them. What the patient really wanted in this situation was often hard to discern. There were periods when the patient seemed to be very clear and indicated that they didn't want to receive pain medications, and other times that was much less clear due to the delirium associated with her underlying illness. So here is the big conundrum. Okay, team is doing all they can to help her with her respiratory failure, and that is one issue. But the issue that really arises in terms of an ethical challenge and a moral challenge for the people involved is, what do we do about this, what we perceive to be a symptom of pain, what the team feels needs to be addressed, and what the family's wishes are and their assessment of the situation. Not an easy question to answer. So I thought what we could do to start off is just to talk a little bit about what her options are or what the modalities are in terms of treatment of pain. And I'll ask Michael to speak to that a little bit and how we assess that and how we should be thinking about the concerns the family has related to side effects.
Okay, thank you. Good afternoon. So I think I probably would divide this into three areas. The first is the issue of assessing and treating pain in a critically ill patient. So clearly this is a different scenario than an outpatient clinic where a patient can talk to you. This is a patient who may be obtunded, may be ventilated, where the ICU care is focused importantly on things like sepsis and hemodynamic stability. So it really becomes a different ballgame. And we have data that suggests that pain can often be undertreated or even ignored in the ICU setting by well-meaning doctors and nurses simply because they focus on other priorities. So I think the first point I would make is that treating pain in a critically ill patient is a very different cup of tea than in an outpatient. The second thing I would say is that it's easy to conflate the questions of pain and agitation. So a patient who is, let's say, mechanically ventilated may not be in pain per se, but they may be very anxious or uncomfortable based on the presence of the endotracheal tube. And we have retrospective data where patients were interviewed after exit from the ICU, and many of them commented about the discomfort associated with being mechanically ventilated. So we want to make sure that we distinguish between anxiety and pain. And then the last point that I would make, Lee, is that of the pharmacokinetics of treating pain in a critically ill patient are different because fluid balance issues are much different, and when patients are critically ill and they're hypovolemic, a lot of their effective blood volume gets shunted, understandably, to maintaining brain and gut perfusion, and so some of the modes of giving pain medication may not be effective that we might do in an outpatient. So team focus, pharmacodynamics, and awareness are different in pain in an ICU patient.
Great, thank you so much. So I think another aspect of this that will be important for us to unpack, another couple of aspects that I think are critical. One is we're not told in this case really much of anything about the faith background of this patient or family, but I think it would be important in caring for this patient to understand some of those issues and to think through how that one's faith might influence both an understanding of suffering, the importance of remaining connected, and those pieces of things. And then two, to understand, I think Michael got at this a little bit, what are the different types of suffering? So there's physical suffering, but are there other experiences of suffering that might be happening here that could be addressed and or relieved? So I'm going to ask Lynn just to comment a little bit on, from her perspective in terms of engaging patients and families in the face of suffering. What are some of the types of suffering and aspects of suffering that you'd be thinking of trying to address in a situation like this?
So it's a really difficult thing to assess when you have a patient who is just miserable. Sometimes you ask how they're feeling and they say horrible, and they can't pinpoint a place. They can't point to a place that hurts. They can't say they're nauseous. They just feel horrible. They're down, they're sad. All of these things that we talked about, pain, nausea, cancer, this can really affect a person's being. And sometimes that is the major distress, is they are not themselves. They are grieving a loss of who they are. In my experience, not as a chaplain, but as a nurse with patients who are very spiritual, sometimes they are wondering if they're being punished. Sometimes they're worried about what's going to happen, and this anxiety can really ramp up, and that's when I call Rhonda, or that's when I call Matt, because they're the experts in really, really focusing on that kind of distress. But it's important for all of us to be able to recognize that. I had a patient when I was a hospice nurse years ago that I knew very, very well, and I was treating his pain, and he was comfortable, and I went to see him, and all of a sudden he'd been fine for days. And I went in to see him, and he wouldn't even make eye contact. He said he felt horrible. He said he didn't want to talk. I worked and worked hard to try to get him to help me understand what was going on. And he said, my pain's terrible, I need more pain medicine, so we worked on that. The next day, our chaplain went to see him and had a long, long visit with him. And it turned out that that distress, that pain he was suffering was spiritual pain, existential pain. And nothing I did helped, but that long conversation and support from the chaplain is what made a difference. Did I answer your questions?
No, that's great. I'm going to engage a member of our audience, Matt, if you wouldn't mind just commenting a little bit from the chaplain's perspective on some of the things that Lynn has shared and sort of thinking through how faith is influencing our perception of suffering. Something that I think the team might need to be cognizant of and or respectful of in that context.
Especially in an ICU setting, I think it becomes really challenging depending on the intensity and the acuity of the onset of this. You know, ideally we want to be able to have this great relationship with the family where we understand a little bit about who they are and where they've come from, what kind of things are important to them, where they value, how they make decisions. And when we don't have that opportunity, that's where we get all this really rich information, like the patient you described. We find out, oh wow, he has a particular faith background that makes him think that he's being punished for this particular illness, or for something that this illness is connected to something that he's done. Or that we understand that his son no longer talks to him because of a divorce or something, right? We're able to unearth some of these things that are causing the suffering. In my experience in an ICU setting, whenever we're all meeting a family cold and learning, you know, their entire life history is running into us all at once, it's a really difficult process of trying to build enough trust for them to share what's going on, about how this particular illness and possibly impending death are affecting the patient and their family, but also what all else they've got they're carrying along with them, right? We were just in a ethics consult this morning where the family was facing the illness and death of a child, but then they also had, in the very recent history, the death of another child. They also had the death of a grandparent, and they were bringing all that to the table. And so, you know, is it physical suffering? Sure. Is it physical suffering connected to emotional or spiritual distress? Probably so. Right? And all that stuff works together to make the situation much worse sometimes.
Thank you. Michael, I want to return to this question a little bit about management of pain, and wondering if you could comment a little bit on, you know, the tension is arising because the team feels that they see signs that are physiologic signs of pain. How reliable are those signs? What else might they mean? How reliable are we as caregivers? Are we just reading from a script that we need to let go of?
It's a great question, because I think that's really one of the crux issues of this whole discussion, is when we have a disconnect between a family's perception and the caregiving team's perception. And specifically with regard to your question, so when a patient can't speak, we really lose the primary means of relating pain concerns. And there actually have been pain scales developed for critically ill patients to address these. So in an outpatient, we might say ma'am or sir, what is your pain on a 0 to 10 scale? And they'll give us a number, and we call that a numerical rating scale. Well, we can't do that in this kind of patient, so we actually can look at 5 physiologic parameters based on things like facial grimacing or consolability, and we rate those on a 0 to 2 scale, and then you multiply that by 5, and you can get anywhere from 0 to 10. So this becomes almost sort of a proxy pain scale. Now, it's clearly subjective because what may appear to be intense grimacing to you may seem perhaps not as bad to me, or vice versa. So that subjectivity may call it into question, but it's the best that we have. However, as you point out, if a patient's tachycardic and critically ill, is that because they're in pain, or is it because they're hypovolemic, right? So if a patient's hypertensive, is it because they have a huge sympathetic outflow because of pain or for some other reason? So it really becomes a question of what a given individual is seeing. And with regards to proxy from the family, so we know that proxy information can be helpful. So we don't want to totally discount the family's perception, but I don't know that we can totally take that at face value and ignore the caregiver's concerns who are following this patient day after day.
Thank you. Yeah. Sonia.
So one of the things I think might be helpful to distinguish, the distinction between pain and suffering. Pain, as we've just been describing it, is often understood in a more physiologic, biologic kind of frame, whereas suffering is the narrative that we give to that experience. And so the narrative for the patient, for the family, for the team may be quite different. And the meaning that we assign to the physiologic parameters may create a certain narrative among the clinicians, but it also may have a different narrative in terms of meaning for the patient and the family. You know, some people see suffering as redemptive, as somehow there's something that is beneficial through our suffering, and other people see it as a harm that we ought to immediately extinguish. So when we view it through our values, the narrative we create is going to be reflected in that. And I think that's sometimes where we end up having these conflicts, is that our narratives are so different and diverse, and there's not often an easy way to bring them into coherence, because the clinician group is really, you know, we're seeing it through one lens. And as we've talked about before, for some families where there's life, there's hope, and we see the situation as one that is just, you know, filled with unrelieved suffering, and our role in causing that suffering is really weighty for the clinicians.
And also, I think there's probably a story here with the family, and that's something that is really worth exploring. Why are they feeling this way? It's not enough to just hear, I want her awake. Why are they asking that? Explore that story a little bit. You can get a lot of information. They may have seen grandma go to hospice and get morphine and be drugged and die in a day. And they're thinking, if we give mom morphine, she's going to die too. Lots of things, like lots of fears and worries are part of that. Also, family might have unfinished business that they feel that they need to talk to mom about, talk to this patient about. They want her awake. They don't want her to be doped, so they can have these conversations that they feel are important.
I think that's a really, really critical point. So I'm going to open it up to the group. Are there questions or thoughts that you have about the relationship between what the family is expressing and experiencing? 2 questions right over here, and a microphone coming your way.
I was just wondering, maybe from the physician or the nursing perspective, what does it feel like for you professionally whenever you recognize that pain exists, you assess that pain exists, and either the patient or their proxy are asking you to either not treat it as you feel like you should, or are asking you to treat it beyond the parameter of what you think you should?
I can tell you as a palliative care nurse who sees a patient maybe for 30 minutes or an hour at a time, how difficult it is for me to see somebody in pain, in physical pain, and not be able to do anything about it. That's me, and our nurses are at the bedside for 8 to 12 hours at a time experiencing that, and I've talked to many of them that are taking care of someone like that, and they are so distressed. Sometimes they don't want to take care of the patient. They won't let me treat him. They want this patient in pain. The distress can really ramp up to a place where, I think Cinda can speak to this too, where there's so much moral distress that it's contagious as well. We've had many ethics consults where actually it's the nurse's moral distress about issues just like this that bring us in because they don't know what else to do. Nurses are instinctively want to make people feel better, and when the ability to do that is taken away from us, it's like cutting off an arm. We can't do our job.
So what Lynn says is absolutely true, and I think part of the source of that moral distress is having a sense of what we ought to be doing and not being able to do it. And I think what Lynn highlights is, and this is true for medicine and nursing, that our primary obligation is to first do no harm, and to at least to attempt to benefit our patients. And when we can't do that, then that really does fracture our sense of integrity. It fractures our identity. How can I be a good nurse and do things and participate in plans that I see the consequences of more suffering for the person that I am committed to taking care of? So there's really a lot at stake, I think, both for the patient, for the family, for the nurse, and then finding a way, how can you have integrity in a circumstance like that? And I think one of the questions that we have to sort of explore is how do I see my integrity as intact when my professional role requires me to do things that I would not choose to do otherwise? And how do we make sense out of that so that it's not a continual assault on our sense of wholeness, who I am as a person, who I am as a nurse? And I think that's really the struggle often, is to try to find our way through that and to make sense out of it so that we don't feel that we've been totally depleted and our integrity is really compromised in the end.
Well, I'm going to just unpack this a little bit further before we go on. I know we have more questions, but both Cindy and Lynn, if you would consider speaking to this question of the couple layers of responsibility. So when you mentioned that, in nursing we instinctively feel that we need to alleviate pain, which I think is very real. And the other layer that is coming up for me is I took an oath as a healthcare provider that I was going to address this. So there's this my personal responsibility, my personal ethic, and then there's this professional ethic, which you began to touch on a little bit there, Cinda. But can we talk a little bit about how those things layer in together and sort of impact on the experience of the provider?
Sure. I became, before I was a palliative care nurse, I became a pain expert nurse, a pain nurse, because that was really a goal I wanted to achieve, alleviating physical suffering. I can tell a short story that may answer this question. I took care of a very young woman. She was 22 years old in very much pain, a lot of pain. Her parents did not want us to go up on doses because they thought she didn't need that much. The patient said, I do, I'm in pain, but then ended up deferring to her father. Our job as nurses too is to treat the patient and the family, And when they're at discourse, it's very, very hard. So something we try to do is to educate the family and help them understand what we're seeing, give them the data that we're seeing so they can understand why we think the patient needs more or less pain medicine, and also educate the patient. And I can tell you that I knew that woman for about 3 or 4 months, and being in the room with her for a short visit, 30, 40 minutes, I would dread going into a room, and I left that room in tears many times, many times. So it affects us deeply as caregivers that can't do our job, and to witness suffering and to not be able to do anything. Really, it does go against our instincts as well as the oath that we took.
So I think this is in many ways the crux of the matter of how do we balance these obligations? And I don't think there's an easy formula for it. I do think that there's a way in which it's important to have realistic expectations for how we work in these complex environments. That I've heard many, many clinicians say, relieving suffering is, if not the highest, one of the highest responsibilities and priorities that I have. So how do we share that priority with the people that we're serving? And how do we have some discussion about whether or not not treating pain is optional, or if really what's on the table is trying to negotiate the boundaries of how, rather than creating the expectation is that we can either treat or not treat. So that we are not creating a situation where we're asking questions that maybe families can't completely answer on their own, and they actually need some guidance by our clinicians around what those boundaries need to look like. So for example, might we say something like, we do have an obligation to relieve suffering, and we want to engage you in thinking about the how of that. And here are some ways that and places where we can work together to try to find a solution. Because sometimes it feels like we have given over this question as a yes or no. And I think there is an argument to be made from a professional point of view that that's not what we were called to do in our professions.
So, take a little, not a detour, but I think circle to a question that raised as someone else discussed this case last week, and that is this notion that alleviating suffering maybe isn't optional, and in fact, when you're admitted to, it could be argued that when you're admitted to critical care, you sign on for a package deal, as it were. That you have, Michael, I invite you to jump in and correct me on sort of our your thoughts on the conversation earlier. But pose this question to the group, and I know we still have a question in the second row, and we will definitely get to that. But just as it seemed like a nice jumping off point to say, is it okay to just, we're going to bypass this question of or allowing a yes or no here, and in fact, when you agreed and consented to be treated to receive critical care at a given institution, management of pain is all part of that. Michael, do you want to speak to that?
So this is really an important issue, and I spent a year training in the ICU after I did my pain fellowship, and it's uncommon, almost non-existent for patients' families to come and debate ventilator settings or ventilator modes or these sorts of things, right? That's considered to be the purview of the treatment team. But yet, in cases such as this, these sorts of things happen, and many, not all, but many intensivists are trained in anesthesiology, and they have expertise not only in cardiopulmonary physiology, but in treatment of pain. It's part of how we train. So I can see an argument where some may say it is sort of selectively undermining the autonomy of the medical team to question treatment of pain when they're sort of allowing them to treat these other sorts of issues. And if I can just, Lee, have a moment to augment something that Lynn said, because I think it's really important. Part of the question we need to look at here is whose suffering are we treating? So not only is the patient suffering, but the family is suffering too. And we want to start thinking a little bit about issues, family dynamics. So I saw a number of cases where a matriarch or a patriarch of a family was getting ready to pass, and the amount of family dynamics that this generated was really quite staggering. So it's important to realize this may not just be a patient per se issue, but a larger family issue.
I think that's incredibly important. So we have a question in the second row.
Thank you. You described the patient as critically ill, and I guess that's by definition why she's in the MICU or what got her there, but she also appears to be terminally ill when you look at the status of her cancer. And I wonder if you viewed this patient in terms of that context, would it change anything about how you view the plan to approach the conflict that we see here?
That's a great question. I actually, if it's okay, going to call on another member of the audience. Mark, would you like to speak to that?
So, okay, so
For
it
those
may
in the back,
be
this is
the,
Mark Hughes.
so I'm a palliative care physician and also co-chair of the ethics committee. So it may be that that's sort of an unspoken reality that nobody is addressing. So obviously she's coming in with the flu and she's on the ventilator. The cancer is there and causing pain, but this idea that she could very well die, that she has a terminal illness, may be something that the family is thinking about but not speaking to. So part of this learning the family dynamics and asking, the curious question about, why are you so concerned about her pain management and the fact that you want her to be awake, may be this concern of, we recognize mom is dying and we want to, be able to communicate with her while she's dying, while she's got this terminal illness. So part of the role of either the ICU team or maybe calling in a palliative care specialist would be to ask those questions of, wow, she's really been through a lot with her cancer and it seems like it's progressed and there aren't treatments available. This is an acute event that she's having with the flu, but do we also need to be thinking about what her goals and wishes and your goals and wishes as a family would be, recognize that she might have this terminal illness.
And I think it's probably fair to say it's an important conversation that needs to be had, but may or may not have a major influence on this dynamic. I mean, it would certainly improve team understanding of all the layers that are going on there, but may not change the tension. That doesn't mean we shouldn't have the conversation, but not always going to have a huge impact. There's a question in the back, another one in the second row, and a question in the back.
Well, I was just thinking that this whole expectation that we be pain-free in some ways is kind of uniquely American, whereas in other societies it's just, you're not supposed, it's just taken for granted that there will be some level of pain throughout life, and the whole expectation that I will be pain-free maybe doesn't exist. And I guess how does that enter into the equation, different being an international hospital that treats international patients?
No, I think that's a great question, and it goes to helping the care team understand and articulate what their expectations are for management pain. Maybe they do truly expect this patient to be pain-free. Maybe they don't. But it's maybe they're just trying to mitigate the experience. But I think it would be it'd be an important thing to help the team begin to articulate. I want to ask you, Lynn, please go ahead.
So I do see many cultures, and in some cultures, the feeling is that pain is an okay thing to experience. That's a difficult thing for us as providers to deal with too, when we're seeing pain, but the patient says no, I don't want anything, I need to do it this way. The other thing is working with the family and just really trying to understand what their culture is and what would be helpful, and to compare cultures. I've done that a lot. I want to respect your culture. In our culture, we work very hard to get people comfortable. Can we talk about that? Can we kind of compromise somewhere in there? Does that make sense? The other thing we do is try to manage expectations. When we have somebody like this with horrible bone cancer, we're not going to get their pain to a 0. So we talk to patients and families about the ability to get it to a manageable level. Often when we have somebody who's in a lot of pain and we know we can't get to that comfortable level, we ask the patient in front of the family if possible. It might come to a spot where we can't keep you wide awake and keep you comfortable. We might have to give you more medicine and you be sleepier and in less pain. What would you prefer?
And just to get back to the gentleman's question for a second, to clearly communicate with the family so they understand that that does not mean that we're, calling it a day, or we're trying to accelerate the demise of their loved one, which could be a possible perception that they may see if we say, oh, well, they're clearly not doing well, their life expectancy is short, so we're going to make them comfortable. We need to make sure that the family doesn't understand that that's, okay, well, we're just trying to, get rid of your loved one so we can move on.
Cindy, you look like you have something. Okay. There's a question all the way in the back.
Hi. I just was thinking about how pain, unlike the ventilator settings, is something that people have experience with in their everyday lives, and that maybe asking the family a little bit about, like, this patient, how does she deal with pain? Like, some people take Tylenol for everything. Some people never take medicine no matter how bad they feel, and like kind of getting a sense of, especially with this patient, like how has she been dealing with the pain from her cancer prior to this hospital visit might give you a context for the person that you're working on, even if the person isn't able to provide that. And also the family's like kind of approach to pain. Like some people do alternative medicine and some people really want pain medication. And you could get a sense of that. I don't know if, I might have missed if that was explored earlier, but
I think that's a great point. So we had the family present, and it would be sort of foolish not to take advantage of what they can share with us. And I do this in my clinic patients. I have a gentleman with pancreas cancer who's sort of sitting there doubled over and saying, Doc, I'm fine. I really don't need much. And I'll look at his wife and say, so do you agree with that? And she'll say, no way. He's up every 2 hours at night. So I do think that there's value in recruiting the family for additional information.
So, pass the microphone over to Cindy.
So one of the issues I wanted to make sure we paused on a little bit is the idea of staff suffering. We've talked about the patient and the family and often the interconnection between their suffering, and I do think that the clinicians are suffering as well. And it's a really challenging place to be, to, as Lynn said, to witness suffering, to feel like you are contributing to it, and to feel helpless to do anything different. So I think it's a place where we do need additional tools and skills. How do we separate what's happening to the patient as it's not happening to me directly? Because I think empathy often puts us in a position where we can take on more of the other person's suffering than is ours to carry. And that we need to be aware of how our engagement can often set up a situation where we may actually be making our own experience more difficult because we do care, not because we don't care. And also to think about how do we look at the consequences of our efforts on the patient and on the family? And is there a way for us to see not just the suffering and partly our own suffering, but to see that there may be a way that we are actually fulfilling our professional obligations by giving the family an experience of their loved one's death that they can actually live with. And at the same time to sort of shift that so we can find some of what we're doing having some benefit rather than it all being negative and painful for us as well. And I think we have to have places where we can talk about those kinds of tensions, because what I hear a lot is we talk to each other on handoffs about it, and as Lynn said, it can be a contagious narrative that sometimes we need to pause and relook at the narrative and to see if there are other alternatives that might be possible that would help us to continue to have a sense of wholeness, but also that's not draining our vital energy by feeling like every day when I come here, all I'm doing is contributing to suffering rather than relieving it.
Yes. Keep right up front.
I wanted to touch on the social context of your work. So pain management and pain relief in general has been a charged issue for a long time, certainly one that was charged with moral judgment. And it took an IOM report, I don't know how long it's been, and Mike, you're going to remember the date, it's been at least 15, 18 years or so, to try and shift the tendency away from under-medicating people in serious need of pain relief, and that changed the entire profession's attitude. Now we seem to be at the other end of that spectrum with a lot of political discourse about opiate addiction, specific substances, families responsible for produce, etc. So I'm sure this produces a certain climate of expectations in society in general. I wonder if it's affected your personal relations and your personal decisions with patients. And I wonder if you think that it affects those who are not physically affected by pain, but like families, whether they are affected by these sorts of social currents, and it enters into your discussions and the decisions you have to make.
So this whole question about the pendulum is very relevant, and I don't know if Travis is here or not, but he gives a great talk about this, about how this pendulum, as you suggested, was over here and now it's swinging. And if you go back to the Civil War, it's gone, I think, back and forth like 3 times now. So as a fellow, there was all this aggressive marketing of things like OxyContin going on, and people were giving it out like crazy, and you were considered to be somehow uncaring or behind the times if you were not subscribing to these theories. And now, as you've suggested, now it's considered to be mandated that we are very restrictive about these. And what I try to do is just simply sit down and talk with the patient and give them a little bit of the history of what's going on. And also, as I think Lynn said, expectation management is a big part of it, to know that I'm on your side, I want to try and work through this with you, but please be aware of some of the societal limitations that we're dealing with. And I've had to have these conversations a couple times with patients who have been on long-term opioids, are stable and doing well, and who are now having their opioids pulled away from them by the system. And obviously this is causing a lot of not only physical consternation, but emotional suffering as well. So there is a pendulum and there is a societal bias against this now, and it's kind of amusing how we never seem to find the middle ground. We seem to swing from one extreme to the other.
I see a lot of worry in patients and families when we start talking about opiates. We've always dealt with questions about addiction and such, and people's misconceptions about it, but it's ramped up by 100% now. One woman that I took care of about a week ago was on high doses of opiates, probably about 100 of long-acting morphine twice a day. She was so motivated to get off of that. She was very afraid of addiction that she pushed the team to get her off of that, and they weaned it over 3 to 4 days down to nothing, and she experienced severe withdrawal. And I think that's something that we all need to be aware of. It needs to be part of our education to our nurses and our house staff that opiates can do good things, they can do bad things, but we can't take them away immediately because that can be really bad.
I think that's a great point. Are there other questions from the group? If they're not, I want to pose a question to you. Okay. So, those of you who are here enjoying lunch, this is your care team. They've just come to you, consulted you. You are the ethics team. And you've come to consult, and they're asking you for your advice or guidance on what they should do to navigate this situation. So I'd love to hear from just a couple of you what types of things you might recommend. We talked about a variety of different aspects of this, but what comes to your mind that you might recommend? And I'd love to hear from a couple of folks, actually, if it matters, whether this patient's in your ICU for 3 days or 3 months. Does the duration of time that this tension lasts make a difference in the types of things you might recommend? So thoughts, anyone?
I was thinking about, and I didn't hear this in the narrative of the presentation, but patients' wishes. Is there anything that we know about, and let's say just playing this out, that they have some sort of preference as to how they'd like these things managed, either in the event that they can't do it, or that they already have something that they've expressed in terms of either the conversation with the care team, or something along the lines of identifying what those preferences might be.
A lot of times we don't know, and we really question the family about what they've talked about, what they think mom would want. There are some different versions of advanced directives now that directly address pain specifically. And the question I posed before, I want to be out of pain no matter what. So that's one thing. Mike, do you have any?
I don't know, Lee, the specifics of whether the patient's wishes were known or not, independent of the family in this case. Can you comment on that?
So the scenario as described, the patient was delirious. So we know that in delirium, mental status and ability to communicate waxes and wanes. So you might have what appears to be a relatively normal interaction with the patient at 9 o'clock in the morning and at 3 o'clock in the afternoon. They're saying things that don't make sense, or indicating things that don't make sense. In this case, the patient was on the ventilator, as you'll recall. And so in the case as described, what we're led to understand is that the patient was delirious, and at times when the patient appeared to be clear, seemed to indicate that they were having pain. And there was some question on the part of the team in terms of thinking through this particular case as described, of whether the patient was, in those more lucid moments, was accepting pain medicine unless the family might have been present and have objected. Does that influence what you would recommend the team to do?
Well, I think it would come back to, I'll say this out loud, just in terms of, if there was something to Lynn's point about something being written down at some point where they might have been able to fill the gap, between the periods of whether she was lucid or not. I think that would at least be informative about, kind of establishing a trajectory where to go with this. And I think, as the case might be with the family, then it's still objecting. If you still have, let's just say for sake of argument, they actually have something written, that's a little pretty powerful indicator, in addition to those times when this patient was lucid, to at least indicate by either facial gestures or otherwise that she was clearly in pain, and if not articulated, yes, give me something. At least I think you could sort of speculate that would be the direction to go.
Okay, thank you. Others?
I think I'd also explore. We talk about the family as a unit, family is made up of multiple people, different roles, children, parents, siblings, and so on. And of course, there is a legal hierarchy of decision-making, which has not been mentioned here at all. But I think I'd first want to explore what is meant by the family and who in the family has what opinions about this. There may be some divergence of opinions, and a more authoritative or louder voice may control decisions when that may not be really in the patient's best interest. So I think I'd definitely explore the various family members, their feelings about this, and also back to this issue about this illness appears to be terminal. She has no cancer treatment options, and does the family know that, or how that the palliative care team might talk about it, or even the oncologist, how they would talk about that with the family to what is her prognosis? They really think she's going to live more than 6 months? That puts a different cast on the tenor of the discussions, I think. But if her prognosis is under 6 months, then the family ought to know that and consider that, and then family members come to some consensus, perhaps.
So I'm just curious about my nursing colleagues. What would you recommend? What would you want to have happen in a case like this? Go for it, come on.
Okay.
So the answer for me would be, yes, it's okay to give opiates when you think somebody's in pain. Please let me treat my patient. That's what I would want to hear.
I think it's the provider's responsibility to lay out all the options, their outcomes, potential outcomes, pros and cons, and also the responsibilities. So from the family side, they know what to expect and lay out everything, let them to choose, and then who is going to be responsible for what. So if that meets their expectation, then everybody will be happy.
Peter, a couple comments on the right-hand side of the second row.
I think that I would be interested in learning more about the other options for pain management besides opioids. So if the family, which types of pain management do they have the concerns about? And is it because of a previous experience, like maybe last time their mom was put on an opioid, it was a really high dose and she got really out of it, or something, maybe there are concerns there with previous use for a certain type of medication, and there might be other types of pain management that they could turn to. But I don't actually know for bone cancer what types of medication are available, but if there were other options, I think that could be explored with the family.
That's a great thought, thank you.
Again, the nursing perspective, I was just thinking that maybe some education of the family in regards to the severity of the experience of bone pain associated with bone cancer, because that may not, it may not be something that they're familiar with or can understand. So education of the family might be helpful, and I would want to relieve the pain for sure.
Great, thank you. Anyone else? All the way back.
I just wondered if you had a family meeting with the family, because that would be my first thought, is to sit down with them and hear their concerns and have nursing be able to express their concern for pain. For everybody to hear each other's concerns and talk about options together. I don't know if you did that or not. I couldn't tell from the example.
That would certainly be a standard expectation in this context.
I think that's a great idea. I think a lot of times we hold family meetings for times of crisis and times of deciding goals of care and that kind of thing. But having a family meeting to discuss pain management is a really good idea. And it doesn't happen as often as it should.
Well, thank you all for being here. It's been a great conversation. I know a few of us will be around for a little bit. If anyone would like to discuss further, please travel safely wherever you're headed. Stay warm and enjoy the snow.